I'm Wan SONG from Samsung Medical Center. It's my honor to talk the topic, the optimal strategy for Trimodality treatment. Who, how, and when. The radical treatment, radical cystectomy with pelvic lymph node dissection is gold standard for the muscle-invasive blood cancer. However, the surgery is very high risk, significant complications up to over 60% and readmission rate and 90 days mortality rate to 55%. And see in the right side, the graph, that there is no improvement for overall survival over 30 years. So it is necessary for the alternative options to radical cystectomy, and one of the things is blood preservations. Many guidelines recommend the preferred or ideal patient selection because it's very important for blood preservation, and many guidelines show that the preferred patient is the clinical T2 and no hydronephrosis and no CIS and maximal TURBT after visibly complete TURBT and unifocal tumor and bladder good functions. And contraindication is clinical T3B and T4 and positive lymph nodes and tumor-related hydronephrosis and prostatic stroma invasion and a history of pelvic radiations and not fit for chemotherapy. And now I show some evidence for ideal patient selections. Most important thing is the tumor stage. As you see in the graph, there is a significant difference in disease-free survival and overall survival according to the tumor stage. And NCCN guidelines recommend that the tumor size less than 6 centimeters is one of the requirements for tumor candidate for blood preservations. And many guidelines recommend that maximum TURBT is very mandatory because the complete TURBT is associated very closely associated with high CR rates and improved overall survival and disease-free survival and very low rates of salvage cystectomy rates. So in most cases of blood preservations, complete resection of blood tumor improves survivors and reduces the rate of cystectomies. Sorry. And coexistence of CIS is one of concern, and many guidelines recommend that presence of extensive CIS is not recommended for blood preservations because it is associated with a low CR rate and high recurrence rate. However, in other parts, panel by SIU, CIS should be considered as relative and not absolute contraindications to blood preservations because it is not associated with overall survival. However, on the curative intent, it is not recommended to include the extensive CIS in blood preservations. When there is a coexistence of variant histology, there is no definite high level of data because of rarity. However, European urology recommend that there is no difference of disease-free survival and overall survival and blood intact disease-free survival according to poor and variant histologies. And very small cases of studies published in Japanese groups, they recommend you that it may be particularly benefit in squamous and glandular differentiations. However, just 5 cases. Guideline recommend that hydronephrosis is not recommended because it is associated with reduced likelihood of CR rate, and it is clearly associated with advanced stage and decrease of survival. As you see, the large group studies published in RTOG study and metastasis study groups, the high CR rate is very lower than hydronephrosis group. Then after the maximal TURBT, there's 2 options, the radiation and chemotherapy. There's 2 types of RT technique, the split dose and continuous dose. The merit of split dose RT is to avoid ineffective RT. However, it takes much longer times. The purpose for the continuous RT is that insists that there is a shorter treatment time is very associated with clear CR rate. However, they do not prove the patient sensitivity and complications. And in meta-analysis, there is no difference the type of RT techniques. So many guidelines recommend that it is not necessary to receive the radiation or chemotherapy alone, and recommended the concomitant chemoradiation treatment, because when we perform the chemoradiation treatment, there is a higher rate of CR rates and improved overall survival rates. So the chemotherapies act as a radiosensitizer, and there is no guideline which is most best type of chemotherapy. However, most guidelines recommend that cisplatin is most commonly used, and because the cisplatin has as well known the renal toxicity, the other option is 5-FU plus the mitomycins, and the alternative regimen is low-dose gemcitabine. Now, when we choose the consider trimodal treatment, the new version of the NCCN guideline recommend that only the blood preservation is here the stage 2 and the stage 3A, and there is no recommendation on more than N2 disease. And one thing is we consider the neoadjuvant chemotherapy because in muscle invasive blood cancer, it is well known that the effects of the neoadjuvant chemotherapy. So in this protocol, after the maximal TURBT, 2 or 4 cycles of neoadjuvant chemotherapy is applied, and after that, the EBL concurrent chemotherapy was used. In systemic review and meta-analysis, the mean 5-year overall survival and disease-free survival, there is no difference of the effect of neoadjuvant chemotherapy. However, this study is very old study, and the limitation is that there's no support for the growth factor and antiemetics, and just 2 cycles of neoadjuvant chemotherapy was applied. This is our study, our hospital's protocol. The names the adjuvant chemotherapy with selective blood preservations. It is a prospective study, and we include the clinical T2 and T4 and 0M0 patients. And at first, we applied 2 cycles of GC cycle, and after that, we restaged with CT scan and cystoscope. When we restages and identified complete CL, we recommend CCLT or cystectomy, and no CL, we recommend cystectomy. Concurrent chemotherapy regimen is weekly cisplatin 6 cycle and continuous radiation treatment, and also it is not published. Clinical CR rate is 42% to 42.2%, and 3-year metastasis-free survival was CCLT in 70%, radical cystectomy 64%. In ASCO 2021, there is many other protocols were introduced, including the immunotherapy, and I'll show you some of the protocols. The first thing is immunopreserve and SOG trial, and that is the immunotherapy plus radiation treatment that excluded the chemotherapy. The protocol is that after TUL, the domvanalimab and tremelimumab was applied, and 2 weeks later, the radio treatment was administered. After the TUL, using the TUL, the response was evaluated. In a very small, although it is very small study series, number of series, the CR rate was 81%, and 1-year disease-free survival rate is 76%. Overall survival was 87%. The other thing is Fujian Cancer Network trial was immunotherapy plus GC chemotherapy that excluded radiation treatment. And In patients with T2 or T4 patients, gemcitabine plus cisplatin and nivolumab 4-cycle was applied, and using the MRI, the clinical restaging was done. In this study, complete response rate was 48%. The other thing is in traditional trimodal treatment combined with the pembrolizumab. And in this study, pembrolizumab was applied, and after that, maximal T1BT was performed. And during the concurrent chemotherapy, pembrolizumab was also applied, and the clinical CR rate was 58%, and 1 year bread intact disease-free survival was nearly 90%. So I think that trimodal treatment is a very reasonable alternative to radical cystectomy in well-selected patients. And there is an ongoing trial after the introduction of immuno-oncology and immunotherapy. And in further study, it is necessary to identify the biomarker for the response and prognosis. Thank you for your attention.